So, when taking into consideration how a medication actually gets into the bloodstream, we also want to think about its bioavailability. And bioavailability is defined by the portion of medication that makes it into the bloodstream. So, if you have 100 milligrams of a drug and you give it intravenously, its bioavailability is 100% because 100 milligrams of the drug will end up in the bloodstream, right? But there are a number of factors that can impact the bioavailability of drug products. The formulation, for one. So extended release formulations can often have lower bioavailability because they are releasing slowly as they move through the gastrointestinal system. We also need to take into consideration the lipid or water solubility of a product as it is able to pass maybe easily or not easily through the membranes of the cells, right? So we want to really think about how the products and the individual variables will affect the extent and rate that the active drug enters the circulation and accesses the site of action. Other things to take into consideration is the individual's GI tract itself. So if someone has a short gut or if they've had bariatric surgery, that can affect it as well. Age can affect it. Younger individuals have higher proportions of water in their system, where older individuals have higher proportions of lipids or fats in their system. So that can affect it, as well as a sex assigned at birth, an individual's physical activity level, some of genetic factors. Their stress and inflammation can affect it. And there are also ways with which absorption can be impacted by other medications. So, for example, certain antibiotics like tetracycline can bind to other products if taken at the same time and cause the absorption of those products to be diminished. Right? So we want to take into consideration a lot of different factors that can impact the relative bioavailability of a product when taken. So when we're thinking about different routes, the bioavailability, and how our bodies are able to receive and move that drug concentration through from dose over time, as you can see here, intravenous is going to be your fastest route, right? It gets into the bloodstream very, very quickly because you're injecting it directly in there. And there's some variability after that. So intramuscular is a little bit slower, has a lower peak. Different types of tablets and administration routes can have different concentrations over time, depending on a lot of factors, but including just how we give the product itself. Next up, we have distribution. And distribution is really a way of considering how the drug disperses or moves throughout the body once it gets into the bloodstream, so how it gets to other tissues in the body. And most drugs are transported either as a free drug or they are bound to the proteins that are found within our blood. There's also a number of different fluids in our body aside from blood, right? We have our body's water, extracellular lymphatic fluids, cerebrospinal fluids. All of these move throughout the body as well and can carry drugs potentially. Things to take into consideration is the lipophilicity of the drugs, fat-loving. Lipophilic drugs transfer across cellular membranes much more easily than hydrophilic, which are water-loving. The blood flow to certain organs or systems are going to be different, right? So there's a lot of blood flow that actually goes to the brain, not as much that goes to the skin, for example. Permeability can be different in different spaces too, where the capillaries may have more or less protection against transference across that membrane. And then, of course, binding, as I had mentioned before. So from an image perspective, you see these little green dots. They are what we call free drugs. So those are drugs that are not bound to plasma proteins or blood proteins. Those are going to be much more free and available to cross over membranes, interact with the sites of action to cause the effect that we want. Drugs that are bound to plasma proteins are kind of tied up. They're a bit too big oftentimes to be able to move through those membranes, and they're not going to be able to reach their site of action. So there are differences in how drugs might interact with proteins to free up or bind up those drugs, right? And not all drugs are plasma protein bound. Some are very highly plasma protein bound. And sometimes if we combine multiple drugs that are highly plasma protein bound, they can kind of knock each other off and create more free drug, which can affect how the medications work as well. So thinking about distribution, we have different compartments or spaces within our body. So the one that we think about when we give, say, a drug intravenously or by mouth or whatever, it's when it gets into the bloodstream, we have that volume, that compartment that is intravascular, so inside of your blood vessels. But then we also have fluid inside of our cells, our intracellular volume, and we also have fat, right? And some drugs will distribute into fat. And then we have interstitial spaces, so the spaces between the cells. So there might be large drug molecules, as you can see on the left bottom there, that are really confined in the circulation. So once they're in the bloodstream, they don't really make it very far out of there. We have certain drugs that maybe are very polar charged, so they have a charge to them that can make it out of the vasculature, but can't really get into the cells. We have drugs that are fat-loving or lipophilic, so the one closest to me right here. These lipophilic drugs are going to distribute into the fat cells and can accumulate there, right? So different drug properties will change how the drug is able to distribute into different spaces within the body.